got a dab now. We've got a dab now. We've got a dab now. All righty. So I promise I'm not going to take 30 minutes because I realised, hey, I've got 30 minutes of talk, 30 minutes of interview. If we finish early, it's beer o'clock. So I will try to wrap up fairly quickly. Now, I was so pleased when Danny told me to talk about this. Please being code for what? I'm going to talk about shared decision making. And the reason why I was a bit taken back was that, when I self-reflected and I looked sort of at my peers, I realized this is something that as ITPologists, and not to blow our own trumpet, but I think we do it sort of innately as a second nature. For those of us who've seen enough patients with chronic disease, with ITP specifically, like really understanding, I think, the burden of disease. And it made me really sort of, like really go through and break down, what do we do so much better than the other hematologists? and I suddenly, thought, at 2 a.m. in the morning, thinking, this is good. I actually enjoy, I'm loving this. So really, this session is all about sort of, for all you in the audience, patients and caregivers alike, it's sort of a glimpse into what sort of, hopefully, is an experience that you have. And I know for a fact that's not going to be for everybody the experience you've had, where you're given an opportunity to have shared decision making. So really, I'm going to break it down and sort of talk about, well, what is it? What is shared decision? I'm going to call it SDM to be cool, not to be confused with EDM, which is doof doof. So SDM, very importantly, is when clinicians and patients together make decisions about treatment or care in general. Now, it sounds like a very, very simplistic statement, isn't it? Like, gosh, how hard could that be, right? You and a doctor together making decisions. Well, this is quite a complex process that, as I said, I think for some clinicians it comes naturally, but doesn't always. And I like to think of it as kind of like a dance between you and your patient. You could be a really crap dancer, but with training, though, you could solve through a bit better, all right? So really, I guess I'm going to hope I could put in the framework to try to, help patients and caregivers. How can you train your clinicians to dance better, basically, is really the goal of this session, okay? So now, this process, really importantly, I think, is the two of you together, you've got to be able to think, talk, and feel through the situation the patient is going through. So let's have a think about that. Sorry for the repetitive thing. Feeling is involved in that, right? So feelings. And I know a lot of, on the spectrum doctors don't feel. So it's really important because really it means that trying to figure out the emotions, the psychological, I think, impact on the disease for our patients. Now, so what are the things that I think doctors do well? Well, they do this very well, talk medical crap, right? So this sort of, the evidence options, the medical bits, right? You've all seen it. They're going, right, you got ATP. What you have is, antiplatelet antibody with glycoprotein antibodies, and what we need to do then is to reduce that with immunosuppressive stuff. And we're like, what? I thought I had low platelets. But that is an integral part of the process, right? Because yes, the clinician needs to have the knowledge, but the thing is, though, that knowledge of the treatment options is just a hypothesis that it may work for you, but it might not, right? And that's really important to understand, because for the doctors, they're just thinking, okay, I know treatments A to D, and I'm going to give one of these to this patient, and it should work. But it is a dance where that particular move might not be great when you're dancing with your partner. So it's about finding, I think, that connection to make sure it's the right dance moves, I guess. This is where the interpretive dance, you keep saying this shit, and then now the inception. God damn it. So how is this SDM process? Well, it requires really three fundamental, I think, kind of pillars. It requires open communication, and really what this means is that, well, ask yourself, does your clinician kind of allow you to speak freely? Are they communicating in a manner that you understand, right? Are they using a lot of jargon and you sort of don't know what the heck they mean by MAB-Thera, when it's rituximab, when it's a B-cell lowering drug, So different ways that we could say the same thing. And firstly, and also, do you feel you can ask questions, right? So it's not just the clinician, but how is that sort of relationship during that consultation? Do you feel comfortable enough where you think, oh shoot, is that a silly question, and you sort of feel embarrassed almost to ask? So, that's the number one thing, that without communication, really nothing could go beyond that, right? How are you going to know what the goals of your therapy is and share that when you're not on the same level in terms of communication? Now, very importantly, I think mutual respect, right? So I'm sure you've all been exposed to doctors with that very old school paternalistic approach where you do what I say because I'm the doctor. That doesn't fly when it comes to complex diseases, complex rare disease like ITP. Now, does your clinician, are they brushing off your opinions or your fears or your questions? Do you feel that the thing is, are you confident with them? Do you respect their kind of medical knowledge? Are they presenting you with those evidence-based options? Are they up to date? And now you know, because you'll be armed now with the guidelines, right? So you could test them. You could test them now. Scary. Now, thirdly, of course, and I think this is really important, because do you feel like there is a partnership? Do you feel like you're both on common ground, that you have shared goals, that you're both in sync, wanting kind of the same thing? And now, what do I mean by that? So I'm going to now slightly have a segue into this really, I think, eye-opening study called the I-Wish Project. So Nikki Cooper, God bless her, along, I think, with Jim and really, of course, I think some of the PDSA, associations, come up with, I-Wish number 1, 2.0 is coming. And it's really looking at this sort of, the impact of ITP on quality of life. So not about any bloody platelet counts, about the quality of life, of this disease for our patients. So you can see that was completed by over 1,500 patients, but not just patients. They wanted to look at what the physician thought, of the impact of the disease. So really, you can see that, with this survey, they want to look at the various domains of a patient's, health-related quality of life. So certain countries were involved, and you can see, unfortunately, Daniel, where were you then? You were omitted out of that, but that's been fixed. And really, very importantly, what it's comparing is a patient and the physician's perception of symptoms and the disease management, right? So really for the first time, I think, well, not for the first time, there has been quality of life, but it's probably the biggest ITP specific, I think, quality of life study. What is the, we have a really good snapshot, what doctors think versus what, ITP patients think. So I'm just going to focus on one of the things that was reported in this finding, right? And that is, when the physicians were asked, what are your most important treatment goals for your patient? And this is what was ranked. They want to reduce the spontaneous bleeds. Number 2, so good on, they're very good. They want patients to have better quality of life, and they want healthy blood counts of their patients as the top 3. And you can see, of course, then symptom improvement and slow or delay progression of disease is sort of the other, kind of to complete the top 5 kind of priorities they wanted for their patients. How did we do? Well, not great, because this is what the patient side. So we kind of got a bit of a match with the top 3. So healthy blood counts. So yes, patients, of course, want a good platelet count. And the thing is that they were more worried, well, you're more worried about preventing episodes of worsening ITP. But look at number 3, not even on the radar of the physicians, is improving your energy levels, right? And of course, improving quality of life is there, and reducing spontaneous bleeding. But for me, the take home is that, there is a bit of a disconnect in what the doctors felt that the patient needs and what the patients want. So I think it's that partnership is that the third domain is where it's so important, because it just highlights that there is a disconnect, and that really the only way we're going to bridge that and fix that is really open communication between us and our patients. Right. So in terms of SDM, well, you first start by trying to figure out what's the problem. I guess for ITP, generally, it's going to be how we're going to manage it. So I guess in a way, that's pretty straightforward. But what we've got to remember as clinicians, though, and what you need to remember as well, is that the insights in terms of what the nature of the problem sometimes only you can tell us that, or I guess a family member whom obviously might be involved in your care. And of course, from the clinician side, we need to somehow extract then what I talk about, patient's biology and biography. What do I mean by that? I need to then, from my end, figure out your disease behavior, your severity of your disease, biography in that, what's your day-to-day life? Are you a mixed martial artist? Do you, like Danny, want to box with a plate at count of 10? So, hope you've given up that idea. So that's about me then trying to extract that information then from the patient. And, already we could see, right? So how are we going to be able to get all those insights? You need to have good communication and good partnership, right? So, but that's the only way that we are going to start the process of identifying the problem and really, have the sort of, all the ingredients in terms of, okay, we need to know what we need to sort of overcome to choose the right treatment. So next bit, I guess, is, as a clinician, as part of the SDM process, we have to do two things. We've got to be clinically competent, so know what we're doing, but really, I think, probably more importantly, exhibit compassion to really come up with a plan that would be suitable for the patient. Now, that then involves that, we need to address and make sure that we have a shared goal. So, and the question you need to ask is, does your clinician know what you want? What's your biggest fear of your ITP, right? And being able to have the freedom to verbalize that, I think, and convey that in a consultation. Now, number two, this is going to be then on the clinician side is, does the clinician is able to give you recommendations based on up-to-date, relevant, evidence. So really, you've got to ask yourself, geez, are they competent and skilled in the treatment of relapsed refractory ITP? And again, I don't want to sling mud at my colleagues, but not everybody is going to be up to date with ITP therapies. Okay, so really, and I guess, as I said, you're now being armed in terms of what is the guideline that, or what the usual approaches to ITP are, and you find that the clinician might be diverging significantly away from that. Really, you have to start thinking about, is this the right kind of hematologist for me, or do I need to find somebody that might be a better dance partner? Okay. So, thirdly, and I think this is really, really important in ITP patients, attending to the emotional aspects of this chronic disease. We all know every patient in this room has been absolutely smashed with Satan's Tic Tacs. Danielle, you should trademark that. Too late, I've taken it. So if you're on steroids, it does not do any good to mental health. Plus the fact that you've been told various things about your disease that can be quite frightening, which certainly heard many horror stories through patients I've seen second opinions of just being fed information that's sort of, it's not misinformation, but really it didn't have the right, perspective when conveyed to patients. So I think that's so important that, you need to find a clinician that understands the psychological impact, of the words that we say, but also what you're feeling through with chronic ITP. Now, very importantly, though, is that there's no point coming up with a wonderful plan of, yes, we're just going to get you to self-inject, romiplostim weekly, and if it's blind as me and unco, you've got to think about, can they actually can I mix the vials? Are they needle phobic? Is there a family member that could do it? So we've got to come up with a practical, sensible, solution in terms of that, treatment selection based on the lifestyle of the patient and personal preference, right? So I think that's very, very important as well. Now, breaking down even further, so how does it all kind of begin? Well, it begins with a conversation, right? And really, one of the first questions should be, what treatment should I have for my ITP? Or even better yet, do I need treatment for my ITP? Is the first start of the conversation. And that's really important, I think, that for clinicians, I think sometimes we've got to be really honest and say, I actually don't know. And most of the time I don't know until we go through this dance on what might be best for the patient. And here's the thing that I think, there will be patients where it's like, doc, I don't care. You just tell me what to take and I'll take it, which is kind of awesome but scary at the same time. But then most patients, though, I think, is that, you know what, well, you need to come up with different options, weigh up sort of the side effects and the potential benefits of each treatment. And I guess that's the thing that you need to come, I think most clinicians will suss that out very quickly in that first consultation in terms of what type of approach might be required when we are presenting kind of the options. Now, I guess what's really, one of the sort of obstacles, I guess, in shared decision making, though, if someone jumps the gun a little bit too quickly, right? So if a clinician sort of, comes in strong and says, you know what, hey, you just relapsed, we need to have your spleen out. As an opening statement, we're going to have a problem because where's the discussion, about preference and whatnot. But similarly, though, I guess, if a patient has armed with a very strong, sort of opinion as well, before there's more open discussion in terms of, what the potential options are, it kind of makes the clinician potentially sometimes uncomfortable going, oh, I don't think, using cyclophosphamide as an intravenous pulse is great for a 22-year-old, So, so there's also on the other side, sometimes, this is dangerous because, not dangerous, but we might end up settling for a treatment option that really, if we're a bit more honest and upfront about, it might not be the best for the patient. Next. So, in terms of SEM, there's actually, when you really geek out on it and look through the literature, there's very different sort of frameworks or what they call forms of SDM. But I've got to say, though, I think for really ITP, the great majority of this particular form that we call matching preferences. And I think this is certainly what most of us would do in the audience, to the clinicians, where patient and clinicians basically we compare, the features. You know what, this is what, rituximab, the pros and cons, limited duration, weekly intravenous infusions versus a daily tablet, maybe a TPO-RA, you're going to take long term. So, by going through, I guess, the pros and cons, you kind of a bit of Sudoku, you kind of figure out, what is the most acceptable, I think, to the patient. And that, I think, by far is probably the most common approach. Now, sometimes, I guess, we might have this what we call reconciling conflicts approach, where, and I certainly have a few patients like this, where they have very strong views where, they probably should have rituximab first, for whatever reason, but they're just so resistant to say that, no, I'm going to die from infection with rituximab. And most of the consultation then, in the shared decision-making process, actually try to dispel or at least unravel why are you so against immune suppressive agents, and sort of in a way, try to dive deeper into figure out sort of the rationale behind that, because that might be for that patient the most appropriate. Now, lastly, I guess there's what's called the problem-solving form of SDM, and that's, for example, when someone, the only thing I could think of is, say you've got a patient who's been on a long-term avatrombopag, they don't want to be on anymore because they're young and they want to go out partying and drinking like me, and they just thought that, I don't want to remember to take a tablet when I'm off my chops at 3 a.m. at night. Can we try to get off these drugs and together, okay, we'll try weaning and see if that works, so really just testing it out and seeing how that goes together, knowing that it might not work, and maybe go up, hit the booze together. So now, I guess, well, how can we help then, foster kind of, shared decision making? Well, I think for clinicians, really, for me, what it would be is, the concept of protecting or, generating that space, that environment to be able to have, this sort of open conversation. Now, what do I mean? Well, it means having a quiet room, for example. Like, don't think it's a great idea if the patient's, getting their intravenous immunoglobulin in an open area where there's all this activity, you're telling them, hey, you're relapsed, let's talk about splenectomy, when there's everything going on. So that's probably not the right sort of environment to have this sort of conversation. And I guess, for me, is really that sort of personable approach to really convey to the patient that, I'm here with my attention solely on you, so we could dance, and think of what we're going to do together. And that I'm committing this time for us to, for really, I want to know what you want, so we'll work out a solution, right? And I think it's really important for a clinician that, yes, we've got algorithm and guidelines, but I think it's a pitfall where some of our colleagues who might not treat a lot of ITP, they might just go through that list and going, azathioprine, or mycophenolate's next. So we'll try mycophenolate. We're going to try mycophenolate. And then your 30-year-old, just married OTP patient might be like, but I'm thinking of starting a family. That's not a great option for me. So again, it's just, don't blindly, for the clinician side anyway, to just go through a guideline and think about what's right for the patient. Now, what I guess can patients do to help, generate this sort of, space for a shared decision-making? Well, I think very important, it might mean that you have a caregiver or a family as backup, to have someone there, to have your back, extra pair of ears, to really help assist in the conversation, maybe ask questions that you might be uncomfortable, a bit shy in asking, to really help facilitate sort of, this whole ongoing dialogue, this dance that we're doing to figure out what's right for you. And very importantly, I think, again, coming back to potentially a treatment where it requires, injections of romiplastim, really to nut out the logistic of it, because you do need to, mix and make it up. And if you're blind and really crap at maths, I am these days, it's not that easy drawing up a syringe. I've tried it. I suck quite badly. So, you've got to work all that out together to say it's actually feasible to put someone on romiplastim. Or if you've had a situation where, we thought it's a great idea, yes, M-plate, okay, and then they tell you, I can't do needles. I'm going, we just spent half an hour talking about this. How did you think it was given? He goes, I don't know. You said injection, I don't know. I thought, I don't know. We're just like, all right, I clearly miscommunicated there in that. Yeah, basically the equivalent of I stepping on someone's foot and dance. So, so that's the one thing to think about.